There we go. Okay. Welcome to the first grant rounds in person in 2.5 years. Thank you everyone for coming. It is my great pleasure to introduce Dr. Sue, who's come all the way from Ottawa to speak to us today about geriatric oncology, which is a growing topic of great relevance. Dr. Sue completed her undergraduate here at Queen's, followed by medical training at McMaster and Toronto, and then had the pleasure of doing a fellowship in geriatric oncology under the tutorage of the late Dr. Arti Hurria. She's one of the leaders in the field of geriatric oncology in Canada, and we are very pleased to have her speaking to us today. So thank you.
Thank you so much for that kind introduction. I am so happy to be here, both in person, but also because to be back at Queen's, which is my alma mater, and to speak in a place where I did my anatomy. So I'm super excited to be here, and thank you people who showed up. I was just commenting that nowadays it's so much easier just to crawl out of bed and show up on Zoom. So welcome to both people here and virtually. Thanks so much. So I'm here to talk about a topic really near and dear to my heart. I was really quite pleased not only to kick off your grad rounds, this is the first one in person in some time, but to hear about that. This is a topic that you guys would be interested in. So I'm really excited to be here about that. Hopefully this clicker will work. The clicker was working 2 seconds ago, but not.
Well, I can always click for you.
Yeah, but that's super annoying. I'll click if that's. Oh, did it move or is that me? Oh, that's it. Okay. Sorry. Okay. Technical issues that even after 2.5 years of COVID, we still have. Okay. So these are my conflicts of interest. Unfortunately, I haven't yet received any honorary respect to older adults with cancer, but I'm looking. So if anyone wants to help out, I'm there for you. Okay. So I'm hoping at the end of the talk that you'll be able to describe maybe some of the evidence supporting something called geriatric assessment, maybe describe some strategies that you can implement that in your practice. And then more maybe as a high level thing, I always hope that after a talk, that you take kind of one thing that you can implement in your practice to kind of overall improve the care of our older patients with cancer. So actually I spoke with someone, I just wanted to kind of have a sense of if we were having, what kind of the mix of people in our audience. So we all know this, we see this in our practice, our population is aging, we see that in our everyday life. I always like to highlight that right now, this is kind of where we are. So we are getting a growth of patients in their 60s and 70s, and that's probably what you're seeing in your population. But what I always like to highlight is this is where we're coming to, is that in the next, from 2035 onwards, what we're gonna see the growth of those patients in their 80s, 90s, and 100s. And I think those are patients that we currently don't feel as comfortable caring for. So really that's where we have to think about. If you feel uncomfortable seeing them now, wait, 10 years, 20 years, that's a large population that we're going to be seeing. They're going to be a large number of patients that we're seeing. And I think that they're going to be a population of patients that want to get treatment. And why is this important? It's important because there's a strong connection between cancer and aging. So we know that there's a growth in cancer, but what we're seeing now is less due to risk factors such as smoking that we might have seen in the past. What this growth of cancer that we're seeing, we're feeling in our day-to-day practice, a large amount is driven by our aging population. And importantly, as you can see, this is kind of where we are now. So we are just starting to hit the kind of beginnings of where we're getting in terms of our older adults with cancer. So this is a really good time for us to start thinking about how are we going to better care for and treat for our older patients with cancer. So what is the challenge of our older patients? Why are they not the same as our younger patients? So I'm sure a lot of you can list this off on your own, but really what the difference is that, one 70-year-old or 80-year-old patient is not like the other. It's not like one of my, so my mentor who I trained with talks about pediatrics, saying milestones. It's very, predictable, right? Kids grow, sit at the same time and walk at the same time. But as we get older, actually we start to diverge a lot more. So, what we're able to do, our comorbidities, our health really starts to diverge. And it often becomes much harder to, just by looking at someone, to tell what their true age is. Are they a really fit person? Are they a really vulnerable person? What makes them them? Our population gets more complex. There are more comorbidities, sometimes less social support, transportation becomes an issue. They're on multiple drugs. Some patients on a whole list full of drugs that can interact with some of things that are relevant to us. And sometimes the implications of having a toxicity can be a lot more impactful. So if it makes a patient not able to take care of themselves, not able to ambulate, not able to function independently, that can be a really, really big deal. I think for anyone, but particularly, I would say in terms as patients get older in age. I think that there's also kind of a misalignment between our patient population and what our system needs. So I think our system values, or we talk about having to see the number of patients, and that's kind of the growth of the cancer population. But I think that, it's tough because some of these patients require more time, but we don't necessarily have the time to give them. So I think that makes it quite challenging as well. And we also have a system where we kind of really silo patients off, where you see a specialist for your problem A or a specialist for problem B, but sometimes patients really experience them as a whole totality. And I think it's very difficult for them sometimes to be like, well, you go see that doctor for that. So that's not my area. So I think that often is very challenging. And we also know that as we apply our data, that many of our older patients, both due to age and due to fitness and health, aren't included in the data that we use on a day-to-day basis to apply our treatment management decisions. So I think that makes things very difficult as well. And an area that's always near and dear to my heart is the idea of training. So many of us probably didn't get a lot of geriatric training. And I think that makes it really tough when we're looking at our older patients. Certainly we have a lot of experiential training. Certainly we're getting a lot of hands-on training as we go day to day. So what do we talk about when we talk about geriatric assessment? So this is really where I think a bulk of the data in this field has been. That's probably where the last decade or last couple of decades really has built up. And so it's really this idea of this process to identify what our care needs, really modify plans or develop a plan. And really the ultimate goal is to improve patient outcomes and care. And I think that's what we're all here to do as well, is how do we improve the care of our patients? And it includes both assessment, so data gathering over multiple domains, use of a multidisciplinary team to discuss that, development of a treatment plan, implementing it, and following up as needed. So I always say that I think most of us don't have difficulty distinguishing these two patients. So someone who's super fit. So the lady on the right is one of the world's oldest gymnasts. This is for 80 something, but I think she's a little bit older now. And then the person on the left, the person who comes in a wheelchair, needs help to get up or can't get up from the wheelchair. I think most of us would understand that she's probably pretty frail. But I think what's harder is the average person who comes into our clinic. The average person, are they, who's, functioning reasonably well, might have one or two health issues, but it's really hard to know how they're going to do once you give them systemic therapy or radiation, that type of thing. So I think that's where it becomes a lot harder to judge how people are going to do. So I always like to parallel and kind of think, we really think about things from oncology in a certain way, and geriatrics is very similar. So in oncology, we talk about staging the cancer, right? We all know the TNM system, this is what we think about. Whereas, I always think about geriatric assessment as staging the patient, staging the aging, okay? On oncology, we're really concerned about biology of the cancer, and in geriatrics, we're kind of biology of the patient. In oncology, we really think about personalized medicine, we think about molecular testing and target therapies, whereas in geriatrics, I would say that geriatric assessment is the idea of personalized medicine, is assessment of the patient to come up with a plan that fits for them. So I think there's a lot of parallels that we can make in terms of our specialties, in terms of the way we think and approach our patient populations. So really the combination of it is really trying to find the right treatment for the right patient. And as my mentor used to say, at the right time. So I stole her phrase a little bit. So what are the domains? So some of you may be really familiar and some of you might not. So I thought it was worthwhile. So really what we're looking at, and some of these things are things that we do. So looking at functional status, often looking a little bit deeper perhaps than just ECOG performance status, but things like, are they independent with bathing? Can they do cooking? Can they be grocery shopping? That type of thing. Sometimes we do objective markers such as walking. I love walking my patients. I think that tells me a lot about my patients. Things like comorbidities, looking at their drugs, not only looking at, are they on the drugs? Are they on appropriate drugs? Do they need to be on those drugs still? what's their nutrition, cognition, so doing a cognitive screen of some sort, and psychological status such as depression and anxiety. So that's great. So the question is there any value to this, right? Ultimately, if you got to be doing something, it's got to add something. So just on a high level, things that it has been shown is it's basically if you do a more thorough assessment, unsurprisingly, you do pick up more things. So it does pick up things that aren't, commonly picked up in our day-to-day assessments. It does allow optimization of the domains or deficits that are found. Often that obviously only works if you actually do something about it. So if you identify something and don't do anything about it, it probably doesn't help anything. It does tend to predict for patients who are going to decline once you put them on treatment, and it does predict for early mortality. What I really want to focus on, though, is the latter two. So I'm a systemic therapy doctor, so I apologize for anyone in the audience who's not, but you're going to talk a little bit about tools for chemotherapy toxicity, because I think some of those are useful, practical, implementable things. There have been a lot of data recently looking at patient outcomes. So predicting for chemotherapy toxicity. So there are really two main scores that have been, or tools that have been developed. One is called the CRASH score. So the key to any good study is pick a good acronym that sounds really cool when you put it together. So it's a chemotherapy risk assessment scale for high-age patients. And basically they looked at a number of geriatric factors and came up with a tool or model. And they basically found that for hematologic toxicity, looking at things like blood pressure, your independence with instrumental ADLs, those are things like cooking, cleaning, grocery shopping, do your medications, the LDH, and they have something called the chemotherapy toxicity score, which is a max 2 score. It's available on their website. I'll show you after. As well as things like your mental status, your cognition, your nutrition can help develop a score. So basically, so this is their list of different drugs. I don't know that it's been updated, I guess, because now we have more new treatments and such. Admittedly, a lot of these are more about classic chemotherapies rather than immunotherapies, which I know is things that people are usually very interested in. And they're basically able to show that based on your score, they could kind of grade out the likelihood of what's called moderate to severe toxicities. And if you're actually interested in using this, they do have a website, the Moffitt Cancer Centre is where they developed it, and you're able to go onto the website and kind of put everything in and it comes out in the score. So the other score is the CARG tool, which is the Cancer and Aging Research Group. And this is the one I personally use. And that's not only because I trained with the person who developed it, but actually I just find it a little bit more practical to use in clinic. So it looks at a few things that we probably already know. So it looks at the top things are things that we probably have in our day-to-day practice. So we look at patient factors such as age and the type of malignancy. They look at treatment factors. So are they getting more than one drug? Are they getting standard doses or not? And they look at labs such as hemoglobin and creatinine clearance. But they also look at 5 other questions. And these questions are looking at things like hearing, falls in the past 6 months, requiring any assistance taking medications, difficulty walking a block, and social activity in the last 4 weeks. And this is something that my patients are able to do. I put it on a sheet of paper, I give it to all my consult patients, and they self-fill it out. Most patients don't have any problems. I just look at the results. So I don't even have to ask them any of these questions. So it's quite easy to do. And then you punch it into a calculator, and basically they are able to predict chemotherapy toxicity based on this. And it's really moderate to severe, so grade 3 to 5. And it varies somewhere between 25% and 90% if it's higher. They were able to show that it's better than performance status. So this is the patients looking at just performance status, and it really didn't predict for chemotherapy toxicity. And they also have their own website, which is on the CARG website, which is the Cancer and Aging Research Group, and it's freely available, and that's what I use. And this is kind of what the results would be. You get a result at the top, which shows you where your patient falls into. And also at the bottom, what I really like is it kind of gives you an idea of what they got scores for. So that kind of gives you an internal feeling of what it is that kind of, and after you do a few, then you kind of get a sense of what are those factors that go into prediction for chemotherapy toxicity. So one of the limitations I will say, I really like it. I think it's a good tool to help inform your patients or have those conversations and discuss those with patients. I think some of the limitations is that it's not entirely clear, like what you're supposed to do with the score. Like should toxicity trump other things? Should you therefore modify your treatment? Should you not offer treatment? I don't know that we know that, other than, thinking about logically what you might do, just as any tool, but it doesn't actually dictate, therefore, you shouldn't give treatment, or you should. There's not kind of a study looking at that at this time. So I think ultimately at the end of the day, just like in our oncology treatments, at the end of the day, we want to know, does this actually improve how patients do? So for a while, it was this big limitation of, well, if you do this, yes, we can detect more things. And yeah, assesses, it can predict for early mortality, but does it actually change outcomes? So we've been really lucky. There have been a lot of studies. There are actually 5 now randomized clinical studies looking at this. I'm going to only present a couple that I think are kind of really illustrate the point. So one was called the GAP70. A lot of these studies are run in the States. And this basically looked at patients 70 years and older with advanced cancer. Importantly, these were patients who had some sort of deficit on their geriatric assessment. So these are not your fittest fit patients. These are patients with some sort of vulnerabilities, which I think is a reasonable patient population to study. These were patients starting a new regimen of either chemotherapy or a drug that had a very similar toxicity. Right. And in fact, it had to be predicted to have about a 50% risk of grade 3 to 5 toxicity. And they randomized about 700 patients to either, this is what I call like a low touch geriatric assessment. So everyone had a geriatric assessment. Half of the group got recommendations for the geriatric assessment, but it wasn't like there was a whole team or something. It was basically a formulaic assessment. And so basically they would do the assessment, they would kind of say, this is your deficits, this is what we suggest people do with this, but they were given back to the clinician to decide. So as I mentioned, there were about 700 patients that were included in the study. These were an older population. The average age was 77, so high, particularly for, compared to a lot of our clinical studies. Granted, this was specifically looking at older patients. The majority had GI or lung cancers. And just looking at kind of what were the deficits that these patients had, a lot of them had issues with physical functioning. So maybe they didn't walk as fast as, a normal average older patient, or they reported limitations in their function. And some had, about 40% had some issues with cognition. So what did they find? They found that compared to usual care, so our regular care, they were able to decrease. There was a decrease in the amount of grade 3 to 5 toxicity from about 70% to 50%. So 20% absolute difference. So 1 in 5 patients kind of benefit from that perspective. And this is, so when you look at kind of the differences between patients, this is despite, great, okay. So that, so patients in the geriatric assessment arm often started a lower dose. So first cycle, physicians that were seeing them were more likely to start them at a lower dose. So unsurprisingly, lower toxicities. They were all, however, they were less likely to have dose modifications subsequently, probably because they weren't having as much toxicity from their treatment. Despite this, the fact that they were starting from a lower dose and often didn't require any dose modifications, there was really no difference in survival. So basically, we didn't disadvantage them. There was no improvement. I mean, we could look at it one way. There was no improvement, certainly, but there was no worsening of their survival. So by starting them at a lower dose, by putting them through this, they lived about the same. So when we think about what is the magic of a geriatric care, what is it that actually makes a difference? I think about 2 things. I think about that probably what it is. It's not only identifying what the deficits are, but management of what those impairments are. And so to illustrate that, I really looked at, there was another study called the GAIN study, which is very similar. It was also a geriatric assessment looking more at a broader population because patients were allowed on even if they didn't have geriatric deficits. And it was what kind I call like a high touch, because they had a whole team that would discuss the results and come up with a recommendation. So more resource intensive. And they were also able to show similarly a decrease in overall toxicity. But when you look at what the difference was, I would say that on both arms, both the geriatric assessment and the usual care arm, there were an average of 10 potential interventions identified per patient. So there were a lot of things that they felt could be improved. In the geriatric assessment arm, 77% of the recommendations were implemented. On the usual care arm, And in this case, the usual care, they were fed back the results, but they didn't have a team to implement it. There were about 12% had implementation. So that probably plays a big difference. So it's not just about identifying what are the deficits, but how do we address them? So this is really where I think a multidisciplinary team is very helpful. Yeah.
What about quality of life? Did they show that? Because I think that would be a very important endpoint for intervention, even if there's no survival.
Sure. So the question, just for people not in the audience, is about quality of life, of whether there's an improvement in quality of life. So there's actually a few studies there, because I said there were 5 randomized controlled studies. So in one of the studies, there was an improvement. There were 1 or 2 of the studies, there's an improvement in quality of life. A couple of studies there wasn't. One of the studies did show, so patients with the geriatric assessment did have improvements in some domains of quality of life, and another one showed kind of more overall improvement in quality of life, probably related to less toxicity. So it has been shown, but not across the board type of thing. Perfect. So kind of just having an idea of like, this is from a different study, but really when I think about it, I kind of think about, well, what kind of interventions were there? Like, are these things that we can do? What are those types of things? So in this other study that was looking at it, they did find that 92% of patients did require some sort of interventions. The most common things were things like changes in medication, referral to dietitians, going to an exercise program, optimizing comorbidity. Whereas certainly in that study, having like formal cognitive evaluations, geriatrician seemed a lot less common. So in terms of like, what are the magic, I think, management of things that are found. And I also think the other thing is probably changing what we do. So if you get results saying that your patient is more vulnerable or isn't as fit as you thought they were, maybe changing that plan also helps. So in the first study that I showed you, about 50% of patients had some sort of change, either in dose, sometimes starting at a lower dose, as mentioned. Sometimes they actually change from having a doublet treatment to a single agent treatment. So that also probably helped. And again, highlighting despite those changes, that overall there was no difference in survival. I also put a little asterisk beside it, because if you look at some of the studies, certainly there are studies that show that it does change oncologic management quite a bit, but there was a study done in Toronto by Shabir Alibi, who had a clinic over there, and he found that actually they changed management very little. And part of the reason for that, I would say, is 2 things. I think one is that if you do the geriatric assessment after, or if it's, a decision's already made, I think it's tough for people to make a difference in decision. Whereas in France, they often do it concurrently. They often have teams that often see both the patient from a geriatric perspective and oncology perspective. But I also think looking at the way the recent studies have been run, I think it's also a change. It's also a cultural change. So if you, have made a decision and if you either don't look at it or you say, it doesn't matter, I've already committed to this, then it probably isn't going to make a difference. So the question is, are you willing to kind of take that result and say, I've already had this conversation with this patient, but now in light of new information, I'm going to go back and talk to the patient and make a, suggest a change in the treatment plan. So I think that does make a difference. And certainly wasn't something that they found at Princess Margaret, where they did the study, but perhaps maybe part of it is education and saying, hey, there's, maybe you should take a second look at this patient and decide if you should make a change. So what do we know about geriatric assessment and systemic therapy? So it can identify deficits, identifies those patients who might need some sort of upfront dose reduction or changes. It does decrease moderate to severe chemotherapy toxicity without worsening survival, and it improves completion of planned chemotherapy. I didn't show the study for that, but that has been shown as well. So taking all this data together, actually ASCO's came up with guidelines published in 2018, so 4 years ago. And they basically came up with a recommendation that they thought all patients over the age of 65 receiving chemotherapy should receive some sort of geriatric assessment to identify vulnerabilities that we don't usually identify on a day-to-day basis in our own assessments. So I really looked at it and kind of summarizing it, because it's quite a long guideline. So this is what they assess at minimum. And I actually think a lot of it's actually not, terribly difficult, some things that maybe we can easily implement. So they basically say at minimum, we should look at, can patients do their instrumental activities of living? So those are things like cooking, grocery shopping, to getting medications, cleaning, laundry, transportation, those types of things. So are they able to do that? So that's something you could easily do. You can either ask or have a little checklist type of thing. Have they had any falls? Typically, I think about falls kind of in the last 6 months. They recommend a geriatric depression screen, which is basically like a 15-question self-administered question. They do recommend a cognitive screen. I do something called the mini cog, which is basically, I really like doing it. It's 3-word recall. So you give them 3 words, you ask them to remember it, you draw, and you get them to draw a clock. So I always draw the circle, I get them to put the numbers on the clock, and I get them to put the time on the clock. And you have to get them to abstract the idea of 10 minutes after 11. So I think it's really informative. I like watching patients draw clocks. And if they draw them very, very abnormally, you probably have an issue there. So it takes about 5 minutes or less. And I just think it's a really neat type of assessment. It's not a diagnosis for dementia, but if your clock is really, really abnormal, if you're really hard at the time, I always kind of hits my spidey sense of, oh, something might be going on there. They recommend asking for unintentional weight loss, which I think many of us do and assess for already. And then they recommend using a chemotherapy toxicity tool, which we already discussed, and something called e-prognosis, which is really the idea of looking at what is their outcomes outside of the cancer. Probably more, for many cancers, probably more an issue in the adjuvant setting than in the metastatic, but depends. Some of our metastatic patients, perhaps depending on the biology of the cancer, this might be more relevant. So understanding that this is a multidisciplinary, this is the oncology grand rounds. I did make a stab at looking at some other, what's the data in other settings. So there actually so in terms of cancer surgery, there's actually quite a robust group of surgeons who are interested in geriatric assessments as well. And so I'm just going to highlight one of the bigger studies I thought was quite interesting. So this is a study looking at what they call geriatric co-management. So this is a study done at Memorial Sloan Kettering, in which they looked at patients 75 years older who were having cancer surgery, hospitalized more than 1 day. This is not a randomized study. This is kind of a cohort study where they looked retrospectively at their experiences of patients who had received geriatric co-management and those who had not. Co-management included a preoperative assessment as well as follow-up in the hospital. And their primary outcome was really looking at 90-day post-op mortality. And so just comparing the groups, there were some differences in the group because this is a just a cohort study. So they did find, patients were marginally older who were sent for geriatric co-management. They were more likely to take longer to get to surgery. Their length of stay was 1 day longer, and they did spend substantially more time in the OR, so 203 minutes versus 130 each. They did have differences in the preoperative albumin as well as their estimated blood loss. That's relevant. So what they basically found is that an overall cohort, the risk of a 90-day post-op mortality was 6.7%, but it was much higher in the cohorts receiving just surgery alone. It was 10%, whereas it was lower in the patients who received geriatric co-management. So there was no difference in adverse surgical events. But this was kind of, not a randomized study, but somewhat compelling in terms of the results. So what about older adults receiving radiation? So I will say that there haven't been as many studies, robust studies looking at patients receiving radiation. And whether that's because, the field's just coming along, or whether because, some of the patients receiving radiation, palliative radiation, perhaps maybe not as useful or as needed, maybe. So there is a systematic review done by Dr. Schumacher from Sunnybrook. They found 12 studies. They looked at four geriatric screening tools, as well as 8 studies looking at both a screening tool and a full geriatric assessment. Most of these studies were done in Europe. So Europe's very leading the way in terms of looking at some of these geriatric assessments in the radiation oncology fields. Many were prospective observational. There were no randomized control studies. And they included, as many of our studies do, looking at multiple different cancer types. And they were able to show, so most of the studies looked at feasibility, meaning are we able to do geriatric assessments in radiation oncology patients? There seemed to be some reluctance for the treating physicians to refer patients for assessments. So maybe thinking about kind of cultural or ideologic philosophies. 3 studies looked at how long does it take. They found that in their studies of radiation patients, it took somewhere between 80 and 120 minutes. And 2 studies looked at whether, again, does it actually change your management? And again, this is very similar, but they basically found that if your treatment plan was in place, didn't seem to really affect what people wanted to do, but if we were undecided or it hadn't been fully finalized, then it did seem to make a difference. In terms of treatment outcomes in patients receiving radiation, they did find that there were some studies that showed that your tolerance was worse if you were vulnerable. And there were studies looking at treatment completion and fatigue and mortality. So it's matters of things. There are definitely studies, but maybe hasn't reached the level of where we've seen in systemic therapy, but I think that they'll be coming. So I'm just telling you this because I really like this new article that I read by one of my colleagues in the States. And basically they're looking at how do you practically utilize this? So they've kind of given a 4-step approach, what I thought was really cool. So they basically say, do the geriatric assessment, which is basically as per ASCO guidelines that I had outlined. They talk about estimating what is outside of the cancer, what is this patient's other health, how does this affect their non-cancer related life expectancy? So this is talking about the tool e-prognosis. You can Google it and kind of look at what they have there. Next, they kind of say, look at both what's the likelihood of treatment efficacy versus treatment toxicity. And so how did they say that? They actually really liked it. They said, look at, is your patient represented in a study that you're trying to apply to? How well are they represented? Do treatment benefits vary by age factors? And is the outcome studied relevant to your patient? Meaning, is it important to your patient, right? Is it, if it's just progression-free survival, is that what's important to your patient? Is it quality of life? Does it apply to what your patient would want? And then they look at, again, in terms of treatment toxicity, was the incidence of side effects higher in older adults with cancer? What is the burden of treatment? And specifically, they're kind of using these chemotherapy toxicity scores. And then lastly, and I think this is really important, and I'm sure we do it, but we do it to varying extents. I think we have to recognize that our patients, especially as they get older, may want different things. So a lot of our studies are talking about survival, right? So survival is important, right? That's totally true. But survival, the magnitude of survival or, someone's survival at, someone who's 80 might be very different than someone's perspective when they're 50, right? So at someone who's 80, survival might still be the most important thing, right? You don't know until you ask, but it might not. It might be function. How well am I going to be able to function? Am I going to be able to take care of myself? What's my cognition going to be like? Or, am I going to have, what's my quality of life, as Nazik highlighted, going to be? And I think we know that as we talk to our patients that it's not always survival that's the most important as our patients age. I do like to always highlight, there was a study looking at as our patients get older, that often they value things outside of survival, which I think is important to know. But I also like to tell people that, it doesn't mean that survival can't be the most important thing. I had someone who was 80 or something, late 80s or 90s, and she kept telling me about this book that she was writing. And she really wanted, this was really important to her. And I have a recent patient who's talking about outlining her family history. So being here longer is really important to her. So I think we can't assume, I think we have to ask. So I think those are really important things to consider. So that's great. So hopefully I've convinced you at least that there is some value. So the question is, if that's the case, how do we actually incorporate this into clinical care? So I really like to highlight a couple of different models that have been implemented depending on everybody's own perspective in terms of their personal resources or their places there. So this is one that's mostly used, I would say, in the States. But is highlighted is that this is probably your ideal, is if you've got one person who's actually trained in geriatrics and oncology, you've got a whole team, someone is able to, assess the patient. And basically advantages are this person's trained, they think about both the geriatric assessment and they think about the oncologic factors to develop a treatment plan, but obviously is not practical in a lot of ways. Here in Canada, I don't think we have anyone who's kind of trained in both geriatrics and oncology. There's only certain numbers. We've got way more patients than we would possibly be able to accommodate. So it's really not, practical for many places. If you're lucky enough to have that, that's great. I think what's more common, and perhaps is probably what they do at Princess Margaret, where they have a geriatric team, and also Montreal also has McGill has a fairly robust team as well, is that this is more a consultative model. So the oncology team sees them, they might refer to the geriatrician and their team, they assess them, they feed back those results to the oncology team, they hopefully talk, and then they sometimes in certain places, such as in Europe, they might actually have like a tumor board where they have a discussion about the patient and come up with a plan concurrently as well. So some advantages, you can see quite a large number of patients, you don't require a dually trained specialist. Obviously, the different disadvantages would be is that, if the plan is made, sometimes the impact of having assessment might not be as high. I think it's cultural thing in terms of that, and depends on how fast the other team can, that also depends on how fast the other team can see the patient. I think practically some places also have what's called an embedded model, in which there's a geriatrician or a resource nurse or someone who's interested in geriatrics who kind of sees with the team, kind of more embedded into the team, and helps to make their own assessments as part of the team to advise the oncologist. And so they work directly with the team, they develop those relationships with the team, they're probably embedded into the cancer center. The other advantage is certainly in the States, they really talked about having a geriatric resource nurse, so having an individual that's very, takes that lead. We have in Ottawa, we have something similar, like a palliative care nurse who has a particular lead, and she's able to have the autonomy to do that. I think that's really nice. The challenge is, I think, just like in oncology, where many of us haven't received formal geriatric training, I think similarly, a lot of nurses haven't received, there's a lot of studies saying that they also have not received geriatric training. So that's also very challenging as well. I think when you're considering, implementation, I think things you have to consider when you're deciding about, what model works for you is really looking at your resources. What are your resources in terms of, the clinician? What are your resources in terms of the multidisciplinary team? What are things in terms of clinic space and funding? Other things just practically when I think about this is like, who's going to actually do it? Is it going to be a multidisciplinary thing, or is it going to be a certain individual person who does it, like a geriatric resource nurse? How will the information be synthesized and disseminated and discussed? And when will it be done? Meaning, is it going to be done prior to your consultation? Is it going to be done after? Those types of things. So after ASCO came out with the guidelines, they sent out a survey looking at, what are some of the barriers to implementation. And it really came down to two things. It came down to knowledge, people not knowing about them or not knowing what to do with those. So hopefully my presentation will help a little bit with that. And then the other thing was lack of resources. So both time and actual supports. So looking at just looking at the time issue, I think, because that's certainly very relevant to all of us. There's certainly many different ways that other centers have looked at doing this. So one would be use the screening tools, self-administered and electronic. So certain places have really looked at what I call a screening refer model. So looking at all patients over whatever age category you wish, doing a screening tool and having subsequent referrals or assessment only in those patients who screen positive. So there are actually quite a lot of screening tools. There was a systematic review looking at this, and there were 12 identified. They vary in length between 1 and 15 items. I don't know the one item one, it seems pretty short. A lot of them are clinician administered, but some were co-administered between patients and clinician or self-administered. Many of them didn't report how long they took, but many screening tools don't take that long. So I'm just going to highlight two of the most common ones. One's called the geriatric 8. It's 8 items, some of which are self-evident, like age. There's no really questions about that. They look at food intake, weight loss, mobility, dementia, depression, BMI, taking more than 3 medications, and also the one that I like, which is how you think your health is compared to others in your own age category or peer group. So it's really quite interesting to kind of see what people think about how you do or not. And so basically, if the higher the score, the better. If your score is lower than 14, you screen positive. The other one is called the Vulnerable Elderly Survey 13. It's basically looking at age, again, self-rated health. So there's a lot of studies looking at how you rate your own health is actually quite prognostic. Looking at your ability to care for yourself and doing special activities. And so the advantage of this one, so a lot of people like this one because it's self-administered. You can ask the patient to do it. You just look at the score. Anything over 3 suggests that they might be vulnerable. Notably, anyone over 85, obviously the screen is positive. You don't have to ask anything else because age over 85 gives you a score of 3. So if you look at this, in terms of sensitivity, the G8 is felt to be more sensitive. It's more likely to pick up someone who has deficits. So you're less chance of missing a patient. Whereas the BES 13 is slightly more specific, meaning that you're not picking up as many patients, so you're not burdening your, and you're more likely to pick up someone who actually has something wrong with them. But there are definitely resource implications for that. So I think that there's not actually one consensus, although the International Society of Geriatric Oncology, they're very European, I would say, where the G8 was kind of developed. So they're very much about a little bit more about that. But I think the question is being very sensitive. The question is, what do you do with all the positives? And do you require, if you can't do a geriatric assessment, is it still worthwhile to do it? In terms of self-administered geriatric assessment, so this is a study done many, many years ago, looking at can patients over the age of 65 do a self-administered cancer assessment. In fact, this is subsequently also done in patients on a clinical study, on clinical trials. As well in the States, I think through the Alliance group. So basically they looked at a 94 item geriatric assessment, which I think is pretty incredible. But they looked at multiple domains. So the domains we had discussed about function, looking at can they care for themselves, what their self-reported performance status was, have they had any falls in the last 6 months, comorbidities, did a distress thermometer, social supports and nutrition. And they found that the large majority, 75%, 3/4 didn't require any assistance to complete this. 20% had friends and family help them, and only 3% required actually help from clinical staff. So this is quite feasible. On average, it took 12 minutes. I always like a median is 12 minutes. I like that someone did it in 2 minutes. I was going to say 2 to 60 minutes. So definitely a big range. But most of the patients found it was like totally fine. They didn't seem overly fussed about it. Notably, the scale only starts at 86. So overall, most patients didn't find it was too onerous for them. And then more recently at Memorial Sloan Kettering, they've actually developed what's called an electronic rapid fitness assessment, and they're completed either at home or on a tablet in the clinic. They look at multiple domains of the geriatric assessment, and they supplement. The only thing they do with the clinician is they do the mini cog we talked about, which is the cognitive screen of the clock, and what's called a timed up and go, which is basically patients sit, walk, get up, walk 3 meters, come back and sit down, and their times doing that. So those are really the areas where they have a specialized nurse who does that. And they looked at it in a large preoperative cohort and 600 or so patients who are on average 80 years old or so. And they basically said 50% were able to do it completely without help. This population did require about a third required some assistance, and 13% were completed by someone else, such as a caregiver. So, the last point I'd like to make is this is, I really like this article that was written a number of years ago in 2017, which is basically what everyone's saying, it takes too long to do a geriatric assessment. It's not feasible. We can't do it. Right. So they wrote this article about this, which I invite you to read. But basically their bottom line was saying, if you look at the cost of, so people who can do a geriatric assessment, can be nurse, it takes an hour of nursing time. They highlighted that a nurse's salary for an hour, at least in the States, is $28. Contrasting it to the cost of many other things, such as CEA. If you look at the bottom, we look at liquid biopsies, $5,800, liver biopsy, $879. So just our PET scans, $1,700 is in the States, but just highlight, I think their point was highlighting that, it's not as expensive as, we put it out to be. And I would argue, I have to admit, I don't have a geriatric oncology clinic, but I think at the end of the day, avoiding toxicities and helping to make the right decision for your patient is important, right? So I think there is, I think we all value trying to help our patients make the right decision. So just to kind of clean up and kind of toward the end, just kind of thinking about, we do now have the data, which we didn't have, several years ago, supporting geriatric assessment. We've got guidelines supporting it. I think there are still issues with implementation in terms of resources. But I think the other thing is really, education is really near and dear to my heart, looking at addressing gaps in knowledge, which is why I'm really happy to be here to be talking about the topic, but also addressing attitudinal issues regarding, is this needed, what we should be doing for our older adults. So we know that most of our trainees don't receive any training on the needs of older adults with cancer. And there have been studies that show as a result, our trainees are less confident caring for an older patient than they are with a younger patient. We know that in Canada, 3/4 of patients receiving some teaching, but that teaching is informal, often in clinic, opportunistic. So it depends on who you work with, depends on who you talk to. So very kind of scattered. And so this hasn't published yet, but I did this as my thesis, and basically looking at maybe what are some of the barriers to teaching. So lack of local expertise, which now we've actually, myself and a couple other people in Canada, because of Zoom and COVID and stuff, we've actually done a number of talks to residency programs across the country. So we are starting to kind of help with that a bit. Certainly when I did my interview, so this was done through qualitative interviewing, we did hear that there was kind of like this disconnect. So yes, we get taught, but then there's a disconnect because we don't actually see it in clinic. Nobody talks about it. We don't actually do it. So there's this idea of like, yes, we know that older adults are important, but maybe we don't actually see it in our day-to-day practice that we're doing something differently. And also maybe some organizational barriers in terms of this culture of the way that we teach, that everything's taught very kind of, by tumor type and such. And then when we talk about geriatrics, it kind of spans everything. So it's hard to kind of figure out where best to teach that. So I think just kind of looking at where we're going, just kind of a few things to tackle. So in conclusion, I think we know that our older adults, our population's aging. Old adults comprise a large percentage of the patients that we see. We know that aging is heterogeneous, and so geriatric assessment helps to stage our aging. It can improve selection of patients for systemic therapy and improve patient-important outcomes. And as I said at the beginning, I think we can all advocate to improve care for our older patients in our daily practice. So just a final plug. So we do have an organization in Canada called I helped develop called the Canadian Network on Aging and Cancer. So if anyone's interested in joining, but we are holding a geriatric oncology conference. We're going to go first in person. Hopefully nothing happens. We've done a couple of virtual ones, but we're going to hold in Ottawa in May. So if anyone's interested in coming or learning a bit more, it is a multidisciplinary conference. And then if anyone wants to go to Switzerland, there is the International Society of Geriatric Oncology annual meeting in Switzerland in October. And in a couple of years, it's going to be in Canada. So hopefully at that point, when we do that, everyone will come because it'll be in Toronto. Thank you very much. And if anyone wants to contact me, you can either tweet at me or email. Okay. And I will open up for any questions.
Maybe I'll
Sure.
start.
Do you want a microphone? I don't know if it helps for.
Or you can repeat the question.
Whatever you guys. That helps. Okay.
I don't know if we don't have a
Okay.
really comprehensive review. This is an area that I think about a lot because we're seeing so many patients that, especially in our area, we have a very high percentage of patients over the age of 65. We're one of the largest kind of retirement communities in Ontario. Just a couple questions. I didn't see primary care kind of involved, and some of the geriatric assessment and the outcome of that is really management of underlying issues that maybe, is just good geriatric care regardless of oncology. And it's, how to engage that group. What is our ownership, especially as we're growing so much in cancer and our work of, dealing with cancer patients, dealing with some of these other issues as well. I would find it challenging to take over management of hypertension, diabetes,
social issues, and is that the role of the cancer center versus collaborating with primary care? I'm just wondering what your thoughts are.
Okay. So just to summarize, is that Kingston has a large population of patients over 65 and over, and essentially wondering about the role of primary care because of the fact that we're pretty busy and their role. And you're right, everyone sees geriatric patients. They do make up a large component of family practice as well. And certainly there's a lot of I know a lot of family practitioners who have done some training in care of the older adult. I think there's actually a training stream, as I recall, like a +1 year type of thing. So it's really interesting. A couple of thoughts, I guess, is that so I'm not aware of a lot of studies. I remember maybe one study done looking just at knowledge base in terms of knowledge base and in terms of interaction with the cancer center. I think that probably a couple of things. I think that one, I would acknowledge, I think that there's probably more to explore there and see what their thoughts are. I think that we don't know a lot about what their thoughts about being delegated some of these tasks are, what their abilities to handle that, what the knowledge base is. I also think that because and the reason I say that it's important is I think that we often have that feeling that when patients come to the cancer center, there's that feeling that they've been enveloped, I would say, by the cancer center. Many of my patients kind of remark, oh, I see you all the time. Why do I need to see my family doctor all the time? So I think that's actually an important avenue to explore. But I think it has to be explored both ways in terms of what do primary care providers see as their role, and where can we collaborate and work together. I think some are very open to it, where I think there's probably a dichotomy and of responses, and I don't think it's something that we have looked at enough from that perspective. I also think that most of the studies have been done in the States, and in States, primary care providers are very different. Their role is very different, I think, than in Canada. From my short time when I trained there, I would say that the perception of primary care is very different from what it is here. There seems to be a lot more feeling that it has to be the specialist, even more so than here, I would say, from that perspective. In fact, geriatrics is a little bit more like a primary care specialty in the States. There are people who go to their geriatrician for primary care type of activities. So not a great answer, but I think definitely an important area to explore more about. And I think the lack of a lot of people don't have family doctors. So I think that will be a challenge going forward. I know Ottawa's lost a couple of family doctors recently, so a lot of people don't have primary providers, but certainly something for an avenue for me to think about for research. Let's do. Yeah, that'd be good.
So that was great talk. I was wondering about social support. I see it only it just came up in this non-country, but clinically valued a lot. And I was wondering, what are your thoughts as to how it can be compensated, or how for functional limitations, and how do you use that in your own practice? And then I just have another question about disparities, and as our population is aging, it's I see those times that now that gas prices are higher, patients are living far away from the cancer center. I feel like we're losing less of them, or they're making decisions not to get treatment. So is there any research being done as to what the population is in terms of rural immigrant population, and how are we doing in that sense?
Yeah. Okay. So first question about social supports. I mean, I think I do explore social supports quite a bit. I think it is really important because even after the practical things that you mentioned in the second part of your question about transportation and such, right? So I do think it's important. I think it's interesting in terms of the way, the way our society is structured. We're very, obviously it depends not only on what we're able to provide as a society, but what your personal supports are. So that's always really challenging. We've thought about this for a bit, but there's also limitations in terms of home care and things like that. I think also about social supports. I also think about, what are the, what are supports in terms of family and various things. How do we tackle it? I do look at it quite often, particularly with patients with cognitive issues or issues that are concerning from that perspective. I think looking into what some community resources are, we do sometimes exploring how some of the geriatricians, so I think that's an area where you can collaborate. In fact, it's somewhere we're trying to build some bridges in Ottawa, looking at, they have a geriatric outreach program and things like that to see if we can better support our patients. I think having someone, these are patients that might do with some sort of patient navigation, or having some patients, having more proactive people being able to help report or reach out to these patients more proactively is how I might look at that. In terms of not exactly the question you asked, but I think when I think about social supports, I also think about mental health, and I think about, loneliness and things like that. I think about that there was some really interesting support groups and book clubs and stuff that they did at Memorial Sloan Kettering. They were talking about developing a program to help engage some of their cancer patients. So I think there are definitely very novel things that can be done from that perspective. In terms of disparities, particularly in terms of, I'm just going to hit the big disparity being, being an older patient who doesn't want to come in for transportation reasons and such. Those are big ones. I think utilizing, not ideally, but I think looking at now that there's more virtual care, not saying that replaces an in-person visit, but I think those might be things when you help that maybe we weren't able to do before, and help in terms of transportation issues for the patients. We obviously have, resources, as you guys probably do, in terms of cancer drivers to help patients from that perspective. Obviously choice of treatments. Again, those are those things when we talk about what is the right treatment for this patient. Do we have oral options? Are there other options that we can offer the patient? And again, I understand your thought about disparities, but that's kind of that discussion again when I talk to patients about what's important to them is, traveling to the cancer center, seeing me, spending X amount of time. When you've got a life-living illness, is that something you want to do, or is it time you want to spend with family as well? In terms of immigrants and things like that, I don't think there's been as much in the States. They do a little bit because they're really highlighted in terms of patients who are Hispanic and such, but I don't think that there's been any particular not a ton of research within that. But I think it's really that intersection, I think, between multiple different disparities that are important to look at.
I think that brings us to time. Wanted to say a big thank you for coming and speaking to us today. That was an excellent talk that certainly gives us a lot of food for thought on how we can better assess and manage our own geriatric patients in our clinics. So thank you very much.
Thanks for having me.